anyone does not know the Stanford HIV sequence database and is interested in HIV drug resistance, then please go to that website. It's probably the best source in the world for anything related to HIV drug resistance, and the reason it's here is because last week they had replaced their website. This is the new visual website of the drug resistance database, and that's probably the most important thing in the world of HIV drug resistance, so I just wanted to start with that. What I'm going to do is I'm going to review drug resistance data that came out of India in the past year to show the new research that's going on. Then I'll talk about a new technology for drug resistance testing that I think is a recent improvement and will definitely be relevant as we move forward, and that's next generation sequencing. So I'll review some data as related to that, and then I'll finish with incorporation of drug resistance testing into clinical care and research limited settings. We've been discussing up to now a little bit about it, and I'll review some recent information that's related to this. So starting with review of the literature in the past year from drug resistance in India, and I'll talk about it throughout the timeline of HIV treatment and resistance. So we're talking about transmitted resistance in naive people before they start treatment, then people that fail first line and develop first line resistance, and then people that fail second line and develop second line resistance, and we've heard some recent data that's related to this. So transmitted drug resistance, and I'll move a little bit quickly. I'll make just the important points that are relevant to this, but these studies have a lot more information in them. So transmission drug resistance from recent research in India shows basically low levels. Here's one study from Pune that found in 52 people, most of which were subtype C infected, 3.8% drug resistance. 2 people out of those 52 had single mutations for the NNRTIs, and the recommendation was to continue surveillance when individual testing is not feasible. A second study from the past year was from South India with Anita Shet's group looking at data from Bangalore, from Mysore, and from Chennai, and again found a little bit higher, but still considered low because it's less than 5%, 4.3% in a large cohort of a little bit less than 600 patients, again showing a little bit of NRTI and NRTI resistance. So it's still considered to be low level. And then the third study that I found from the past year is from Kanchipuram in Tamil Nadu, and they looked at 36 people and found 2 people that had transmitted drug resistance with 5.6%. So the reason I'm pointing a question mark is because 5% is the cutoff between low and maybe intermediate level. And I put in at the bottom of the slide the mutations that these 2 people had, and I would say that because the first person had 4 drug resistance mutations, we can question the fact that it is transmitted, because this is a lot of mutations to be transmitted, and there was not enough information in this paper to figure out how much research they did about whether this patient was previously exposed to antiretroviral therapy, and this is why the question mark is there. But if this is true, then it's definitely sort of a trend upwards based on the prevalence that I've showed you up to now. Quickly, this is a transmitted drug resistance global view showing from large amount of studies, 287 studies, more than 50,000 sequences in individuals globally, showing an increasing trend in transmitted drug resistance. This is on the left in sub-Saharan Africa. You can see up here that there's a trend of increasing drug resistance. The x-axis is time since treatment was started, and the y-axis is prevalence of transmitted resistance, and the size of the circle is the size of the study. This is not seen, at least in this data set, in data from South and Southeast Asia that included some data from India. You could see that the line here is even going down. We can discuss why that is, but we're not going to do it right now, but I think the bottom line is that surveillance is definitely needed, as in some locations transmitted drug resistance might be increasing. Then really quickly, the impact of transmitted resistance, we all know, is not good, meaning if you have transmitted resistance and are put on treatment without the knowledge of that, you will fail more. And we showed this in the 5175 ACTG global trial in multiple subtypes. And India had 2 sites in Chennai and in Pune that enrolled patients to this study, but showing that pretreatment drug resistance impacts treatment failure. So moving to first-line resistance study in the past year in India, bottom line is they all show that there's a lot of resistance when people fail first line, and we talked about it yesterday in the discussion. And so in this study from Tamil Nadu and a little bit over 200 patients, they found around 90% of drug resistance, NRTI and NRTI, which is very high. And there was a little bit of a tendency to have more resistance when people were on nevirapine-based regimens compared to efavirenz-based regimens. A second study that relates to the talk from Nari that we saw in the previous, or 2 sessions ago, I guess, about the 12-month treatment follow-up done in 2014 in about 80 patients. They also found high-level first-line resistance. Here it was 79%, again with high levels of NNRTI resistance, a little bit lower level of NRTI, 59%, with a very high level of K65R, 53% in people who were receiving tenofovir-based treatment. And they also found high levels of multi-NRTI resistance, and the bottom line is that linkage to care, viral load monitoring, and adherence are extremely important in order to minimize this first-line drug resistance. Another study from the YRG Care group, again, found very high levels of people that were failing tenofovir-based first line. Here it was 90% resistance with high levels of NRTI, NNRTI, and dual drug resistance, 71%. And one of their conclusions was that AZT it's supportive of the data that AZT is a good second-line NRTI, like the guidelines say after someone has been exposed to first-line tenofovir-based first-line failure. Another study from the Chennai group, again, found high levels, 94% of first-line resistance. This is in people who are on AZT-based first-line treatment, which is an alternative first-line recommended regimen. Again, high levels of dual-class resistance, 75%. And they also looked at an aspect of accumulation of drug resistance, and they found limited accumulation of thymidine analog mutations. And we can talk more about this, but there's an interesting discussion in the paper of why that might be. And then I think this is the last first-line resistance study from Manipur. I put very in parentheses because they actually summarized it as high resistance, but it's a bit lower than what I've shown you up to now. It's 53% resistance in 76 people, and I think it could be discussed further why that is. There wasn't too much information in the paper, but whether adherence was an issue or other factors, it's questionable. Again, just a global overview. The study was mentioned yesterday about the tenofovir-based first-line people who failed with high levels, in this case 57% of tenofovir resistance. Bottom line is this high-level resistance is existing globally after first-line, justifying further surveillance of viral load and drug resistance. And then lastly, second-line resistance. There's not a lot of information about this. I found one study from Varanasi that in very small number of people, 16 people, showing high level, 50% of major protease resistance. This is higher than reported in other locations. There was another previous study a couple years ago from Chennai showing almost as high PI resistance in second-line failures. And again, this could be a topic of a talk in and of its own of why that might be. But those people were also failing with other high-level resistance to NRTIs and NNRTI that was probably carried from first line. But the good news is that 88% of those people were still susceptible to darunavir, which would be, as we heard, a third-line option, which is a good one. This was not a second-line resistance study per se, but I just added it since it talked about the feasibility of rilpivirine in treatment in India. And without going into too many details, this is from Bangalore and a large number of patients. They looked at the rilpivirine use, and a couple of their
conclusions was that primary resistance is rare, but whether one wants to think about rilpivirine as first line, we'd have to be cautious because viral load at baseline seemed to be higher in India compared to other settings. And you can see the graph on the right. I think India, this is showing viral loads at baseline, and if I can get the pointer, this shows India. And you see that as compared to other settings, the viral load is higher. And what the reason to that can be discussed, but the bottom line is that since it might be higher, rilpivirine might not be a great consideration for first-line failure. But what they also did is they compared different mechanisms of subtype C versus subtype B and found that rilpivirine might not be as good as a drug for subtype C compared to B. And as we all know, subtype C is the main subtype here. So that's an important consideration. And so their bottom line is that if we're thinking about rilpivirine as a experienced patient drug, it could be useful, but we might need resistance testing in order to incorporate that. Okay, so that was a quick review of the last year in research in drug resistance in India. Now let's talk about a new technology, or relatively new technology, that I think would be important as we move forward, and that's next generation sequencing. So we talked yesterday about drug resistance testing, including Sanger and point mutation assays, which you'll hear more about in the talk after me. We talked about two aspects of Sanger sequencing. One is that we get full sequences with a full list of mutations, and another one is that it's very limited in its sensitivity, if you remember, meaning it can't get those minority variants. Next generation sequencing will cover both of those. It could give us information about all the viruses that exist in the patient's blood, including those that are minority variants, and it will give us the ability to look at full sequences, even though it's not going to give them all at once. It'll give us small pieces of those sequences that if you put them together, you'll get a picture of the full sequence. So I'm not going to talk about the technology of it in and of itself. It's becoming more inexpensive. It has numerous applications into what we're talking about, which is drug resistance as well as others, and it can definitely detect minority variants and show us the quasi-species, as we call them, of the viral variability and diversity in a patient's blood. There are different reviews of the incorporation of the next generation sequencing. This graph shows the decreasing cost of per genome for using next generation sequencing, which is pretty incredible as far as the decrease, and I think that will even go forward lower as we go forward. Very hard to control the pointer, but this graph shows the increasing number of studies that incorporate next generation sequencing in HIV, and the majority of those studies, as you can see here, were on HIV drug resistance, but not only. So just to make the point that this is an important and evolving technology. It can detect drug resistance below the level of detection of Sanger, which is represented here by the green line. And you can see here in the circles the different mutations that were detected at lower frequencies using a very high coverage, which is shown here in black, a very high coverage of this diversity, intra-patient diversity, which is feasible by this very sophisticated technology. Now, a few studies that incorporated this and this study shows basically that NGS can improve resistance detection. It's a study from France on multiple subtypes, and NGS was able to detect many more clinically relevant mutations as compared to Sanger. There are different studies that compare the different platforms for next generation sequencing. There are a few platforms, and they each can have different characteristics. Here are the different platforms in the top and the different characteristics that we can discuss about what is good in which scenario. You can talk about the different amplifying method. You can talk about the read length. You can talk about different aspects of these, and everyone that's considering incorporation of this technology should take those things in mind. But they were all able to generate very usable, very good data, and some key differences might be needed to take into consideration when we're thinking about it. Now, there are different challenges when we have these new technologies, And again, without going into a lot of details, those challenges can lead to errors when we interpret this very large amount of data. For example, when this group from Switzerland did an assessment of how many sequences that could be built into a full sequence from these small reads are real versus those that derive from error, the real sequences based on this data that was made from plasmids where they can really look at those errors. Basically, the top part of this slide are the only sequences that were real, and the bottom part of this slide are sequences that were basically a result of different errors, making the point that we got to be very careful when we have these new technologies that are introduced, and we want to interpret what we can from them. And there are different methods to do that. This is a primer ID method that, again, without into going to a lot of details, basically marks every one of those sequences that we put in order to make sure that what we're seeing when it comes out is a real sequence from the patient as opposed to some error from the process in and of itself. And this is still evolving. Lastly, I want to talk about the incorporation of drug resistance into clinical care globally and in India, and I think that's a very relevant point, which I think we heard about from past sessions as well. So this could be related to it could be to Sanger, which we talked about. It could be related to point mutation assays, which you'll hear about in the next session, in the next talk, and to next generation sequencing. So this study from India basically developed a lower cost drug resistance genotyping ability for local labs using Sanger sequencing. And they showed that it was much more cost effective, and if that is incorporated into the life here of patients in Kenya, it can improve drug resistance interpretation and drug resistance testing, and that's been done previously by the Chennai group a couple of years as well. So this is good news. How about incorporation of next generation sequencing, which I just discussed with you, into clinical care? So this group from Canada basically looked at a way to incorporate this technology using hundreds of samples at once in order to come up with a good representation of drug resistance in patients. And they were able to have a large percent of success, showing that this can be done. There was great concordance with conventional tests, and they suggest that this could be a very widespread way for widespread individual testing and regular surveillance of drug resistance testing. And the similar concept was done here in India as well by Neogi's group. And they basically did the same thing. They developed a cost-effective way to incorporate next-generation sequencing into their pipeline in order to come up with drug resistance interpretation that could be cost-effective and be incorporated into clinical care. I think this is from their paper, and you can see here that whereas in population sequencing or Sanger, there were a lot of undetectable mutations, those were detectable using next-generation sequencing, as well as detecting the frequencies of specific mutations, which is something that the conventional method cannot do. There are a couple of studies that looked at the ability of next-generation sequencing to predict failure better than Sanger. This is a group that did it in data from Spain, and they basically were able to show that this is an ROC curve, and if I can get the pointer, I can't, but what you can see is that data from next-generation sequencing were better predicted treatment failure than Sanger sequencing. And this did the same thing, or they were able to show the same thing, and not only treatment failure, but time to treatment failure. So the data that's very sensitive from the next generation sequencing, shown here on the left, was able to predict better than Sanger sequencing, shown on the right, the time to failure, which is, as we know, very important clinically. This basically did the same thing from Uganda, making the same point. Another important concept when we talk about the ability to incorporate drug resistance testing into resource-limited settings, including into India settings, is the ability to get samples from the patient to the lab. And so these are just pictures of a few methods that tend to either dry blood spots on the upper right, or sample tankers on these two pictures, or HEMA spots, which are new versions of the dry blood spots that enable us to quickly get with a pinprick in the latter two options, samples from the patient to the lab in a very cost-effective and quick way, and maybe can help incorporate drug resistance testing into such settings. So finally, to conclude, transmitted and acquired drug resistance is a major problem for patient care in India and globally. I put transmitted parenthetically just because of this trend that we're not seeing yet here of increase, but there is a concern that this will happen as it happens in sub-Saharan Africa. Continued resistance surveillance is needed, particularly with changes in treatment and monitoring, and we talked about viral monitoring a lot and its direct association with increased drug resistance. Existing and new technologies for drug resistance detection are promising. We discussed some of them and should continue to be evaluated and developed. And in my mind, incorporation of drug resistance testing into clinical care using these new methods will be inevitable. So I thank you very much for your attention.
Some questions I do have, but we'll have it at the end of the
Why should we really care about resistance? And I think that, compared